Hi, everyone. Welcome to our webinar. We're going to get started in about 1 minute. If you'd like to say hi, we'll have the chat box open for a few minutes so you can introduce yourself, let us know where you're coming from. And also thank you for the 120 people that already responded to the poll. If you can answer the poll, we're going to be closing the poll in 1 minute too. All right, let's get started. Good morning or good afternoon, depending on where you are. My name is Harumi Rees-Riley, and I would like to welcome you to the third webinar of our Every Step of the Way Through the 1,000 Days Blueprint webinar series. If this is your first time, we wanted to give you an extra special welcome and hope you come back for the rest of the series. We value your time here, and we hope that you leave today with some new insights and eager to advance continuity of care and make all spaces in your community CHESS breastfeeding friendly. Thanks for responding to the poll, introducing yourself. We'll leave the chat box open for a few more minutes. Here's a bit about us. NACCHO is the National Association of County and City Health Officials, and our mission is to advance the work of local health departments and its community partners to create healthy, thriving communities. We have several different programs at NACCHO to help advance our mission. Within NACCHO, the CHESS breastfeeding program falls under the maternal, child, and adolescent health portfolio. Currently, we are in the 4th year of the Reducing Breastfeeding Disparities Through Continuity of Care project. Through the past 8 years, almost 8 years, we have assisted over 100 communities to implement local level lactation support projects and have developed many, many resources and stories from the field. You can access all those in our website. There you can also find the previous webinars in this series. Most recently, we launched the Continuity of Care in Breastfeeding Support Blueprint, and that is what this current 8-part webinar series is all about. So this project is funded by CDC, the Division of Nutrition, Physical Activity, and Obesity, but the views within the blueprint and these webinars do not necessarily represent those of CDC. We also want to acknowledge that the content in the blueprint is a result of collective inputs from over 100 individuals. And finally, we want to state that today's presenters have no competing financial interests to disclose. Here's our continuing education credit information. By watching this session live or the recording, you're eligible to receive all these continuing education credits. This series is accredited by CDC and meets the quality training standards. Stay put, we will share more information on how to get each of those at the end of the webinar. So we hope by the end of today's session, you are able to describe continuity of care in breastfeeding support, the role of partnerships in establishing continuity of care, and that you are able to identify strategies to establish continuity of care. So here's our agenda for today. I'm so very excited because of this amazing panel for today's session. Everyone you see here were actually part of the making of the blueprint. They've all participated in the continuity of care constellation meetings during 2019 and 20. Each of them brings a different, unique perspective and expertise within the continuity of care spectrum. The blueprint would not be as comprehensive as it is if we didn't have all these complementing points of view. It's like everyone bring a unique piece to the whole puzzle. I've continuously learned so much from each of them and hope you do too today. So I'm going to kick off just giving a background on recommendation 2, turn over to Linda Kopecky with the Minnesota Breastfeeding Coalition. She also brought a special guest that you hear more about. And also later we'll turn it over to Janna Simon from the Illinois Public Health Institute, who also brought a special guest. And then we're going to turn it over to Dana and Jessica from the Carolina Global Breastfeeding Institute. Then we're going to reconvene for Q&A. So please share your questions throughout the webinar using the Q&A box, okay? So before we get started, let me hear some of your personal experience navigating your community. I'll ask some questions, and please answer by saying yay or nay on the chat box, or you can just give me some reactions. So have you ever really wanted to go somewhere, but then you had the kids with you, so you did not go because the place did not seem kid-friendly? So yes or no in the chat box. So a lot of yeses. Next question, have you ever been to a clinic that had posters with picture of people that made you laugh or cringe because they seemed so fake or did not look anything like you? So lots of yeses, someone no, okay, good. Next question, have you ever been given cute marketing material freebies like pens, t-shirts, quiz balls, hand sanitizers, or sample of products directly from providers or their staff? Yes, yes, plenty. Yes, 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 okay. Next question, have you ever wanted to partner with an organization to do a project together, but you had no idea how to start, did not know who to reach out to support your efforts? Yes, 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 yes. Okay, thank you. And last question, have you ever, you or the clients you serve, being asked by the childcare programs to sending more breast milk for their child because baby's still hungry? Yes, yes. I like the yes, yes, yes. All right, thank you. Thank you for sharing your experience. We will close the chat box now so we can really focus on the speakers, on absorbing speakers' wisdom. But thank you. If you answered yes to some of these questions, which seems most of you did, you probably experienced some type of gap in supportive environments in the community, right? So we're gonna get a quick crash course on continuity of care just to set the context here. Continuity of care framework already exists for decades in so many other healthcare fields and has been proven to be cost efficient. Continuity of care in chest breastfeeding support is achieved by consistent, collaborative, and seamless delivery of high quality services from families, for families from the prenatal period until no longer chest breastfeeding. Continuity of care results in transitions of care that are coordinated and fully supportive of families throughout their infant feeding journey and during the first 1,000 days. So you can see here, this image is our firsthand, right? It's our part of our blueprint infographic that we are completing. This is going crazy here. All right. So I wanted you to look at the shaded area that is like circled there in the middle. The top row, where you see a lot of people, represents communication and coordination among various providers from prenatal to postpartum. And this represents one of the dimensions of continuity of care that's called management continuity. Middle row represents the informational continuity and illustrate both birthing person and baby medical records traveling together with the family and being shared from one provider to another. The third row on the bottom represents the relational continuity, which is the care interactions between family unit and providers, and care that should seem continuous from one provider to another, respectful, family-centered, and culturally responsive. So, as you see from the middle row, is that continuity of care framework focuses more on the clinical aspects of service delivery, but to a less extent, the health system infrastructure. But we know that lactation support within public health involves far more than just direct services and clinical care, right? Public health works on improving the community context, which you see there circled around the outer circle. So the healthy choice can be the easy default option. So This outer part of the infographic illustrates the need for the community environment to also be consistently supportive. And this is what we're going to be focusing on today. So continuity of care for most healthcare fields involves communication, coordination among providers, but within CHAS breastfeeding also include this consistency of supportive policies and systems and environmental solutions in the community. So the continuity of care approach aims to create a lactation safety net in the community so families do not fall through the cracks when transitions from into a hospital, from a provider to another, when joining a childcare facility or returning to work, or anywhere really across the first 1,000 days. So besides care provider, there's so many other players that influence the infant feeding journey. So this jelly bean diagram you see here is a local health system diagram adapted to the local CHAS breastfeeding landscape. And this is to illustrate the wide range of stakeholders who has a role in established continuity of care by ensuring that all families have consistent, continuous access to supportive environment systems and policies. So recommendation 2, focus on strategies for each of these community spaces. And while each of these spaces should be proactively supporting CHAS breastfeeding, there's also a need to build linkages between each of these spaces. So today we're going to be talking about creating lactation supportive environments within these stakeholders that you see circled there. And you also hear stories and tools from organizations that are literally thinking outside of the box or outside of the internal jelly bean space, because this is a jelly bean diagram, and going beyond their walls to actually establish continuity of care linkages among the organizations. So you see there the link between ECE and healthcare providers, and food pantries and WIC and milk banks. So this part of continuity of care has little to do how much you know of lactation science or how good you are in providing lactation care management. It's really, I like this quote here that says, for public health interventions to be successful, more than expert clinically focused knowledge is required. Lactation support is very dependent on social cultural contexts and draw on so many varied disciplines like health education, public health, social sciences. So here's the blueprint recommendation 2. You can see them in the blueprint. It mainly uses the PSE approach to create those friendly environments. We don't have a lot of time to dig deep in the concept of policy systems and environmental changes applied to breastfeeding, but you can look at this journal article that we published a few years ago, really digesting all the concept and applying to CHAS breastfeed. So here are the recommendations, 2 strategies. The first top ones represent making the community breastfeeding friendly through family-friendly policies, designation of programs, and to award lactation supportive spaces, and social marketing campaigns to normalize CHAS breastfeeding. The bottom ones are tailored to organizations serving postpartum, pregnant and postpartum families to create this internal continuity of care, and includes organizational assessment to understand internal operations and opportunities to support CHAS breastfeeding, eliminate all formula marketing, policies and procedures to continuously provide lactation education and support, training our staff, identifying champions that Linda's going to talk a little bit more about. And the most innovative one is the community donor milk programs. So we are currently implementing the CHAS breastfeeding blueprint, the CHAS breastfeeding blueprint implementation grant. And these are some of our grantee spotlights working on this recommendation. Lactancia Latina is doing a lot on their workplace environments, especially with meat processing plants. BENFA is working with their childcare provider. ASAP is working with their health centers to improve the environment. And for the Kids Health Start have been working with lots of businesses in their community to improve their environments too. For REACH recipients, this is Stockton in California. They have done so much in the policy implementation within their church that you see on the right, and doing some community events to pamper lactation parents, as you see with this pumping spotting bus. And also another REACH rock star here is Montgomery, Alabama, the Wellness Coalition. They've done a lot of cutouts of families, like real families from the community, and they have 48 cutouts out in the community, in the church, and university, and many others. And they also been creating a sense of community. You see there the billboard and community parents giving shout outs because they through an assessment, they identified that breastfeeding in public was a stigma in the community. So you can read more about them on our website on the recommendation too. And now I would like to turn it over to Linda.
Hi, Linda Kopecky here. So I'm currently with the Minnesota Breastfeeding Coalition as the interim executive director. You can go next slide. And so we know that the overarching goal is about creating a built environment that's fully supportive of positive health behaviors and all of that, right? But what this is really about is right now there's competition between people being able to choose optimal feeding for their children and then living their lives, like going back to a school or going to work or going to the medical provider's office, going to the museum. There's some competition. What we need to do is really eliminate that competition. So there really is no need to choose between them, but you can optimally feed your child and you can live in the world around you. Next slide. So my background is public health, master's in maternal and child health from UNC Chapel Hill. Lactation, I've been in IBCLC and community engagement, and Boulder County and Colorado and now Minnesota. And I looked at the participants and I see some colleagues from Colorado and I see some colleagues from Minnesota and then colleagues from other places. And you'll see some pictures and you'll see some examples that you would recognize. And that's what I'll be sharing today. You'll see little projects that give a little bit of life to what I'll be speaking to. I have a partner with me today, and that's Linda Deck. She is the executive director of the Minnesota Milk Bank for Babies, which is a newer milk bank in Minnesota, and we're so glad to have them as partners. Next. So I've been working in this area of establishing breastfeeding friendly environments for many years now in Colorado full-time, and now as the ED in Minnesota. And when I look at what really lends to, what can create success, it can boil down to 6 things. And you'll see these are reflected in the different recommendations in the blueprint and also in best practices. But this is my version of what the essentials are. So we're going to click next slide. We're going to start with finding relevance. So why would organizations want to improve their policies and practices? We in public health think it's, it's the right thing to do, right? Or we think we have a designation program, that should be enough. Well, you know what? That's not always enough for an organization to improve their practices and to develop policies that are supportive of lactating employees. Sometimes it's about having the money available. Sometimes it's about the competition with other businesses. Sometimes it's about a particular employee that they need to support and they want to retain. So finding that point of relevance with the different organizations is going to be really key. Next. An example from Boulder is, this is one of the organizations that we worked with early on in our project in Boulder County. It's Night Eyes. It's manufacturing. This is an organization that tends to do the right thing environmentally. They try to do the right thing for their employees. They wanted to support their lactating employees. They had that in their sights, but they really didn't have an idea of how to do it. They wanted to be competitive as an employer. They want really good employees, but Boulder County had some money. So we offered them some money to help set up a lactation space. And that's really what tipped the scales from wanting to do it to doing it. And so they set up lactation spaces. They created a lovely policy. Next. The next essential is enabling ownership. So that this is not Linda's program. This is not the health department's program. This is that organization's program. So really making sure that when you're working with organizations or community partners, they make as many decisions as possible. They know their culture. Their lactation program really reflects their culture, reflects who they are in the community, how they present themselves to the community. That's going to be important. And sometimes that takes a little bit longer. Next. An example is our work with the public library system in St. Paul. We started working with them about 4 years ago. And they had a VISTA volunteer that was a great champion, but they worked one library at a time, and they really sort of took it on and said, we're going to do this, and we're going to do it in our own way, in our own timeline. They took a couple of years off because of the pandemic, but just this year they reached out and said, we're interested. If you have some more funding, we're interested. We want to just finish this with all of our libraries and develop a system-wide policy. Now I'm going to let Faisa tell the story of the Rondo Library. We can't hear it, Harumi.
The private lactation. The library is a perfect example of a public space. So we're at the Rondo Library, which is an excellent example of a public space that set up a private lactation space and also has many semi-private lactation spaces available for families.
I was very excited because I see a lot of people needing the space. I see women who bring babies with them. Sometimes they have not only their babies, but they have other children that they're watching. If they wanted to breastfeed, people would ask for a private space. So it's nice to have our own designated area for breastfeeding or pumping.
Many public spaces have a private place for prayer, and that can also be used for pumping or breastfeeding should a family need it.
We could have just put a chair in there, but it's not comfortable. You know, like if you just put a chair in a storage room, it's just a chair in a storage room. Having the lighting, having the rocking chair, having stuff that that would make someone feel comfortable to be in there. It's just nice. We do have to add it to our cleaning schedule. We have a rotation and designate somebody to clean. It's a little bit more work, but it's worth it because you have a space that someone who may not come to the library or who may not stay at the library for a long period of time because they need to breastfeed their child can use the space and stay longer.
So just so you know, that's an excerpt of a longer video that we created with St. Paul Ramsey County Public Health, just about how to set up a breastfeeding friendly public space. The third essential is recruiting and equipping champions. I want to remind you that this is different from the previous one. So they're really two sides of the same coin, and they both definitely resonate with the recommendation 2.6 that the previous essential is really about organizations creating their own program. And this is about those champions. And those champions can be at any decision-making level. They can be the frontline worker up to the CEO of an organization. And we as lactation and public health experts, our job is to make sure they have all the resources, all the agency or the ability to make movement within the organization. They have all the leverage possible to take that passion for supporting lactating employees, taking that passion to the nth degree. And they can create excitement. They're going to be with that organization long after we are done working with them. So that also creates sustainability. Next slide. One of my favorite champions, this is Nathan, and people are really interested with the Minnesota Breastfeeding Coalition's work with food pantries, and I'll be highlighting him in a bit, but he's been with Pillsbury United Communities for about 12 years, and he started as a nighttime janitor, and now he's director of food systems. But he's one of those champions that we want to make sure that can go as far as he can within his organization with that passion for lactation. Next slide. So we started working, this is just a deeper dive into our work with the food pantries, and we started thinking very seriously about working with the food insecurity partners after George Floyd was murdered. And there's quite a bit of civil unrest in the Twin Cities, Minneapolis. There are a lot of food deserts that popped up, and little food distribution sites and food pantries. And we saw formula going into boxes and to any family that had an infant. And we've known that there is a potential for food pantries to be a conduit of formula to families. But this really exposed that as a critical need for understanding each other and seeing if there could be a partnership. So Minnesota Breastfeeding Coalition spent a year just having conversations with our community partners, with everything from the little food closet that's in a church to the state level partners that do advocacy or the big food banks. And we learned a lot about them. They learned a lot about us. And then finally, we received some funding through the Association for State and Territorial Health Officials, and then additionally some funding through NACCHO to do this work. Next slide. And we are working with 3 food pantry systems throughout Minnesota, and you can see them here. Cochise County is up on the Canadian border. International Falls is right on the border with Canada. And then 2 systems in Minneapolis. And we want to make sure this is a collaborative process as possible. So everything we did as a team. Minnesota Breastfeeding Coalition folks and Milk Bank folks and WIC, you'll see in the middle picture, the woman in the black shirt with the colorful leggings, that's Tanisha. She's a WIC peer counselor. So WIC is definitely a partner here too. We created client surveys together. We developed the questions together. And the client surveys were to understand the client's perspectives and how they view the food pantry. Would they even view the food pantry as a source of lactation support? We presume that they would welcome that, but we didn't want to make too many assumptions. So we asked those questions. Is that even a site that you would consider receiving lactation support, their food pantry? And some other questions just about their experience with food pantry, their experience with human lactation and infant feeding. And each of those client surveys was a minimum of a 5-minute conversation. And we had 57 that we collected throughout the 3 systems. And you'll see the clipboards. These were in-person conversations, well masked. And we went to their sites during their produce pickup days. And then we also co-created environmental scans, which was much more about what is happening in the food pantry and the flow of breastfeeding support items, or the flow of formula from coming in to going out of the food pantry. How are referrals flowing through the system? How are people trained? How's the education flow through the system? And then we made sure that the data was really easy for the food pantry folks to understand. But this is about enabling champions. So next slide. So we definitely had champions at each of those sites. On the left, you'll see Ashley, who is the director of Falls Hunger Coalition. And that's a coalition of partners across Cochise County. And Pastor Andy is in Little Falls, which is a very small community up in Cochise County. And he's the pastor of a small church. And she has partners all over the county. And what we did to equip her to be a champion is we helped her understand the data that was collected through the client surveys and environmental scan, and be able to discuss that data with her board of directors and discuss that data with her community partners, so that everybody was at ease with that data and could make their own recommendations about how to improve the systems up in Cochise County. The middle person is Stuart, and he's the director of the food pantry, which is at North Point Health and Wellness, which also has a federally qualified health center. It has WIC there. It's kind of a full service system in North Minneapolis, or the northern part of Minneapolis. way we were able to equip him was we actually were able to buy some time for that system. And so when he was hired a couple of years ago, he sort of acquired a staff that wasn't necessarily his own staff. Somebody else had hired them before he came on as the director. And he has a tremendous passion for supporting lactation, and the staff, not at his level of passion. So over the past 6 months, he had and related to COVID and to other things, he had nearly a total staff turnover. But he was able to hire staff that was his team, and as passionate as he is. So now he is able to work as a team in North Point, and not just him trying to get his staff to come along with him. So having different funding sources was how we were able to make sure that he was in a position to do his best work within his organization. And on the right is Nathan. I also mentioned Chosia and Awal, who are two leaders in their community health program, and they're Somali. And it turns out that the food pantry, our work created more of a stronger relationship between the food pantry system of Pillsbury United Communities and the community health. But Nathan, when we met him, we thought, okay, here's this guy. He's worked there for a long time. Yeah, we hope that he cares about lactation. We hope he understands something about this. But as we got to know him, we found out that he studied anthropology in school. He lived in Peru. He speaks Quechua. He did a lot of research in the Quechua community and the Incan community in Peru. And his thesis for his undergraduate degree was actually in the composition of breast milk. Who would have known that this man is, already an amazing champion for human lactation. So we just were able to work with him to make sure that he could work as far as he needed to within his system to make it as fully supportive as possible. Next slide. Essential number 4, making it easy. We just got to make it as easy as possible for our partners to be as successful as possible. And we can develop assessments, self-guided processes, forms, policy templates, connect our organizations or our partners with other organizations and other partners who are doing great work and similar work. Nobody wants to create a policy from scratch. Give them something that is something they can adapt, or a template that they can fill in. Before and after photos, really helpful for not having to start on at square one. We want to make sure that they can start at square 10 or square 20. We also found out that a lot of times we do reimbursement if organization needs to buy chairs or tables or something for a lactation space. That can be a barrier in itself. So making it easier by upfront payments if that's possible. Also going to them, you saw with the food pantries, we went to their produce pickup days for the client surveys. We went to their sites to have conversations. Cochichin County, way up north, 4.5 hours away from the Twin Cities. I went 3 times last year. They were over the moon, appreciative of me making site visits. Next slide. So quickly, an example of this is what we're doing with the Minnesota Breastfeeding Coalition, and we have a lovely grant from the Minnesota Department of Labor and Industry, and we're using it to create a full database of resources, videos, webinars, templates, samples for working with workplaces and childcare. And Erica just put in the chat, you can use that link and you can go to the 90-day challenge page and feel free to look through any of those. Some of those are national resources. Feel free to download and use any of those resources. And we're trying to make it fun too. So it's a challenge, and you can order a challenge kit. And we have office hours where you can drop in and problem solve. We had the Department of Labor at our office hours to share with our partners. Next slide. And back to the food pantries, I'm going to turn this over to Linda Deck. And the theme is, how do we make this easy? Well, we did our best to make it easy for this food pantry.
Yeah, I'm Linda Deck. I'm the executive director at the Minnesota Milk Bank for Babies. We are one of 31 milk banks in North America, and we are in Minnesota. We're a startup. We just got going about 2 years ago. Being that we've just got going, we are also in our strategic plan wanting to address access and equity to donor milk. As you know, there can be an expense to it in order to process it and to ensure its safety and distribution to our babies, particularly our NICU babies and special care, those in special care nurseries, well babies as well. We also distribute to outpatient families who are leaving the hospital who just may need a little bit of milk as a bridge until their mom's own milk comes in or baby's issue kind of, resolve. And everyone knows how those first couple of weeks can go. So in addressing this issue with access and equity, in Minnesota, we currently do not have coverage by MA or insurers for donor milk yet. So in the meantime, one of the things that we're trying is piloting this project. And as Linda mentioned, with all these other pieces, the survey assessments, or environmental scans kind of thing at our food pantry systems, we received this grant applied for and received a grant through the Association of State and Territory Health Officials to give this a try. One of the things that we do is distribute milk through what we call outpatient distribution sites. And in order to be able to do that, they need to have certain requirements met. And looking at this distribution site, a food pantry, as a distribution site, North Point Health and Wellness has came up because of their unique status, as Linda mentioned. They're a full service health organization. And they also happen to have this community food pantry. They are a full service food pantry. They are already familiar with food safety regulations, and they are set up to handle perishable food items. If you see the picture in the upper right hand corner, behind Stuart is a refrigerator. They also have freezers. And in having that ability, he didn't have to bat an eye at things like taking temperature monitoring and reporting and things like that. They already do it for to maintain their own licensing requirements. So that was already done. Our idea was to provide what we call a bridge bag, donor milk, pasteurized donor human milk in quantities of 5 bottles per bag. The bags were acquired for us from WIC through another grant, and provided the means for putting in these 5 bottles in addition to some resources as well. So these bridge bags, we call them, are meant for families who are intending to breastfeed and at no charge, as with any other food item that comes from the food pantry. They do have to be eligible for the food pantry and by filling out an application and becoming a member of the food pantry. It's the way food pantries, track their own participants and in order for them to acquire more funding. So the intent then is to provide this bridge bag for breastfeeding families who need a little bit of milk in order to meet their goals and of wanting to breastfeed their own babies. They're eligible for up to 2 of these bags because according to being accredited by the Human Milk Banking Association of North America, a prescription is required for greater than 10 bottles. So by putting these bags of 5 bottles in each, that will allow them up to, come back up to 2 times. And as you know, in those first couple of weeks, just a little bit of supplement can help. Sometimes too much supplement can actually do more harm and cause more problems. So the idea is that these resources down in pictured here, they're not just given a bag of milk and said, good luck. They're also given resources. The referrals come from WIC as well as North Point providers. And when they come to pick up a bag, they also get these resources in this picture right to the left here of 2 peer counselors, one of whom is Tanisha, who you saw before, and Sierra, who are trained breastfeeding peer counselors with the Hennepin County WIC program. There's information about Hennepin County WIC, and then we put in materials about how to store, handle, and thaw donor milk safely. We have this material also available in Spanish as well. So they come from with referrals to WIC. These materials were developed, and we provide the donor milk as part of the package here. The materials and things we put in together, and the bags came from WIC as well. And then, so the idea is, if they need help, and most people coming for donor milk, there's usually a reason for it. We want to be able to provide them some resources to be able to get assistance with breastfeeding, and thereby having access to the peer counselors and also the lactation providers at North Point would help in doing that.
Thank you. That's it's a big program and a really short amount of time to summarize it, but we'll definitely entertain questions. Thanks, Linda, so much. Okay, the fifth essential, and I think we all are pretty familiar with this, moving practices to policy. A lot of times we think it's just because of sustainability, right? It's how to keep the program going longer than the good intentions, but it's also a way to cover all the employees, and employees that may not always be the first ones to be covered by good intentions or good practices. It also is a good way to clarify responsibilities on both parts, on the employee's part and the employer's part. Next slide. So this is some of the work we did in Boulder County. Just a couple comments before we hear from Melissa, who is the person here. A lot of times when I hear about counties working on lactation policies for staff, it's really starting with public health. We started with the whole county, which I think really made a difference. So all the employees that are county employees. So Melissa, who's a jail deputy, was covered under this policy, where if we had started with public health, it may have been quite a while before she could have been covered by the policy. The second one is, I know a lot of people are very interested in working on policies and practices for inmates. That's a different conversation and a different approach. Supporting employees can get more movement on supporting inmates. Starting with supporting inmates can get movement on supporting policies, so they can play off of each other. This one's really about employees. So you can play Melissa's video.
Linda, we will skip this video for now. You can share the link in the chat box, and then we can.
So I'll just summarize really quickly. So Melissa is a jail deputy, but again, as I mentioned, that she would not necessarily have been able to take the lactation breaks or to have pregnancy accommodations if the policy was just with public health. Extending it for the whole county was helpful for her, because her department had to opt out if they wanted to. And actually one department did opt out of the policy temporarily, and then after they saw it in action with the other departments, they opted in. So that's the beauty of having a countywide policy. Next slide. And this is going to be the last essential, which is working locally. So we have a lot of statewide programs of statewide breastfeeding friendly environments programs, but you know, our local partners, they know their champions, they know their community's culture, they know how people communicate. Chaffee County is up in the mountains in Colorado and surrounded on 3 sides by mountain ranges, actually. And it's pretty small. Salida is the main town. It's about 6,000 people, but they know their town. They know their community. They know that everybody reads every inch of the newspaper. So if you want to talk about lactation, if you want to promote something, you put it in the newspaper. They know to celebrate all of their partners. They even created a friendly competition on Main Street. I don't know if that was their intention, but they were going up and down Main Street talking to different businesses about how do you support employees, how do you support the clients, and getting little window clings in their windows. And then the businesses that didn't have the window clings started calling public health, and they said, how can we get a window cling, because so-and-so on either side of me have window clings. So it started that conversation about how they could improve their policies and practices. So last slide, that's all I have. And but you'll see a lot of these essentials are reflected in the recommendations number 2 and the different points under that recommendation. And I just want to say thank you for listening. And this is a quick survey that we have that, you know, you think who are the partners that you are engaging? So please complete the survey.
All right, thank you. Thank you everyone for filling out this poll. It looks like you healthcare providers and WIC are the ones that you're partnering most with. That's great. I hope you're gonna have more ideas here by the end of this webinar. Can we share the next poll, Erica? If you can fill up this poll too, Linda. So this is what this poll is about, the essentials that Linda just presented about. The 6 essentials, right?
So Hermie, do you have the results of that poll about the essentials, right? So, and I think this is just something to consider when you're thinking about all the essentials, that a lot of times it is finding champions, but the other pieces are important too. So you have to start somewhere. Sometimes you're starting with a champion, sometimes you're starting with policy, sometimes you're starting with relevance, and you start somewhere, but making sure you cover all the essentials will eventually be pretty important.
Thank you, Linda, so much. I love the way you articulated the breastfeeding friendly essentials, and hopefully we're gonna have a lot more breastfeeding friendly environments in the country, and especially the work with the food pantries and milk bank. So now I'd like to turn it over to another superstar who has been most recently impacting the public health breastfeeding field, Janna and the Illinois Public Health Institute. So we're going to talk about their CDC, state and physical activity recipient, and have developed so many great resources for communities. We'll share some in the chat box too. So Janna also brought a special guest. So Janna and Anna.
Great, thank you, Haruma. Good afternoon, everyone, or good morning to those on the West Coast. My name is Janna Simon. I'm the director of our Center for Policy and Partnership Initiatives here at the Illinois Public Health Institute. I'm really excited to talk about our work today with federally qualified health centers and rural health clinics across Illinois. And we also have one of our partners, Anna Anderson, who's at Near North Health, one of the health centers we worked with, who will talk a little bit about their project. So just a couple of minutes about our breastfeeding continuity of care work here in Illinois. You can go to the next slide. We are about 3 years into this space around promoting continuity of care and breastfeeding support in Illinois. And we initially pulled stakeholders together through our Illinois State Physical Activity and Nutrition, or SPAN grant, that we received from the Centers for Disease Control and Prevention. But we used a broader statewide multi-sector coalition that we've been running for about 10 years as the backbone for that work. And so we had lots of partners interested in nutrition, maternal and child health, and other chronic disease prevention groups who we were able to sort of pull from. And while we were newer to the breastfeeding space, those stakeholders have been doing this for many years. So we've served as a coordinating backbone entity with lots of partners around the state. And out of the SPAN work, we were able to have the opportunity through some of the ASTO Breastfeeding Innovation Grant funding in 2020 to work with our federally qualified health centers and rural health centers. And what we have found is stakeholder engagement and really focusing on policy and systems change level at organizations and institutions has really helped lead us towards a large amount of change we've seen here in the state towards lactation support and continuity of care. And while we've been funding lots of local community work, running something that I'm about to share with you through the state and having some peer sharing and networking across the state has been really beneficial to helping our health centers move forward. So what you see in the middle is that red circle. And we have also now expanded our breast and chest feeding work with with support from our state health department through Title V funding, also all towards the same goal. So you can go to the next slide. I wanted to share, we have a goal and a vision statement, but these are our 3 objectives we came up with through about a year of stakeholder engaged planning. You can see the bubbles on the outside are all the different inputs into how we came to these 3. So we have community advisors, we had breastfeeding stakeholders and change leaders, lots of our coalition partners, breastfeeding experts who work through our WIC regional breastfeeding task forces across the state. We did environmental scans and focus groups, et cetera. And we came to these 3 objectives. And you can see that the first one is about increasing the number of places that are supportive of breastfeeding. And the second one is around making sure that lactation support professionals have similar lived experiences as those in our priority populations. And for our grant, our priority populations were under-resourced and lower income communities, communities of color, and rural communities. And so when we came up with the health center initiative, it really looked at these first 2. We wanted to both increase places, health centers, that are supportive of breastfeeding, and try to focus on the workforce representation to make sure that people with similar lived experience as the populations that we were hoping to address in this project, we're getting lactation support to folks like them. So you can move to the next slide. So like I mentioned, we decided to engage health centers. We used our partnership with our state association of primary care health centers to help advertise this opportunity. And we had a request for application and we had several folks apply. So what we did was we hosted a learning collaborative where we had folks come together, but the RFA itself was to ask health centers to identify someone on staff. It didn't really matter who on staff, but someone on staff who identified as having similar lived experiences to want to get trained as a certified lactation consultant or specialist, and that we would pay for them to get trained. And we gave a participation stipend to the health center to identify someone at the health center who had some decision-making power, who could think about how the health center could make changes at the institutional level to sort of support this increased capacity they now had with a newly trained CLC or CLS. And so that was what the RFA was finding someone who could commit to the training and that the organization was willing to commit to changes at their organization to support that person to improve lactation support. And then we offered a peer learning community for all of the health centers engaged, and of course, focused on that transformational change. Next slide, please. During the learning community, we gave some information and resources related to what institutional change could look like. There are a lot of examples out there, especially in health centers. And we really encouraged and focused on community and patient engagement, making sure that ideas weren't just being come up with from staff, but was an interaction with the population they were working with to say, what is it you need? What's missing here? What could we be doing differently? And really focus on engagement to help develop the action plans they created. Of course, we know that there's these health center specific lactation support resource guides. There's the first one there is out of California, 9 Steps to Breastfeeding Friendly. NACCHO, of course, has done a lot of work with community health centers as well. And so we shared these guides and did some training with folks, both around the community engagement, as well as strategies that they could take at their own organizations to improve lactation support. We also, of course, got their staff into the CLC or CLS courses, and they did all sorts of things, from training their entire staff and creating new workflows to utilize their new lactation support. They developed referral systems. Some of them changed the way they were documenting infant feeding practices in their electronic health records. And some actually went all the way to adopting breastfeeding friendly policies at the institution. And I wanted to share here this document that you see the image of is a strategy document we developed to support a lot of our work through both SPAN and this project that highlights examples from across the country at various types of organizations to improve lactation support at the institutional level. So you can see the link there. And this speaks to a variety, including health centers, state agencies, virtual settings, community-based groups, hospitals, et cetera. And it gives strategy examples with links to other places that have done those strategies, so you can get a sense of some of the options out there. So we shared that. And this is what we saw. So I have 2 slides that give examples of what the health centers did. So you can see this first one here, which is sort of central southwest Illinois. The lactation consultant we trained sees all breastfeeding patients and provides education at discharge at the hospital. And then they have the local FQHC nearby. In Chicago, there was some standardization around infant feeding documentation, as well as an in-service to all providers around how to now document this. And this was to help them get a better take of how their infant feeding practices were even going and collecting some data that way. We see in the bottom one that the lactation consultant would take a specific follow-up visit with all families at the one, and then also offer one-on-one for those who needed more support. If you go to the next slide. This clinic at the top, they added a breastfeeding screening question to their template for all well child visits. So it was just asked as something that, you know, it hadn't been necessarily standard before, but they made it standard to always ask. The center in the middle, they trained one of their home visitors and then developed a referral process in their electronic medical record to get folks, the providers, to be able to refer to her. And finally, at the bottom, there was a new process created where the newly trained support staff always saw all newborns at their first visit postpartum, and they also developed a lot of educational materials as well. So I'm going to turn it over to Anna, who's from Near North Health, to talk about what they've done with their project. Anna?
Hey, yeah, so I'm Anna. I'm the Director of Nutrition Services over here at Near North. So what we've been working on is really increasing the number of providers who are CLS trained. So who you see on the screen here is one of our providers that we're able to send. Her name's Tiffany Brown. She's our nursing clinical coordinator. She's an African-American nurse. She breastfed her own children and fostered 14 moms who breastfed. So she wanted to improve her ability to support new parents in breastfeeding, especially because a lot of times, you know, that's who they see first. Most of our centers do have WIC attached to them. So we do have that benefit, but it's always good to have some providers in the room as well. So we've been updating our policy on staff breastfeeding education. We've developed an FQHC toolkit that works towards becoming breastfeeding friendly, and we probably, and our reach is about 6,000 parent baby diets per year. So one of the other things that we want to make sure we have is breastfeeding rooms in all of our clinics, and that every provider here knows that we have it. And we're just going to continue to send more providers whenever they're ready. So that's what we've been doing here at Near North.
Great, thank you. Next slide. So I just wanted to lift up a few key takeaways here. And I know early on in our focus groups and with our stakeholders, we heard often that, you know, we train people as CLCs and CLSs, but then they don't necessarily get jobs where they can make a difference, or it's hard for them to really make change. We heard that a lot early on, and we even did in our first year span an IBCLC prep course for folks. And again, the same feedback. Okay, now I'm an IBCLC, great. Where can I go to do this? And so what we decided to do was to sort of turn the model on its head to say, you need to find an organization that has people who are already working with pregnant and parenting families and get them to identify someone and train them and get the leadership buy-in at the beginning that that person would be able to use their newly trained capacity. And so that worked, and we got a lot of interest in it, and having requirements for folks to send their decision makers to this peer learning community. We weren't sending the CLCs and CLSs to the peer learning. It was the decision makers who were required to come. Of course, some of the CLC, CLSs joined us as well, but that created the buy-in at the institutional level to say, okay, we need to change the way we do work so that the person we're now training can see and help families as needed. So I would, highly advise that as a model. It was quite effective here. And of course, learning collaboratives and peer sharing and training is a great way to reach a large number of folks at once, and to offer also support to each other when they're going through something similar. So I always encourage that model, and focusing on policy, process, and procedure changes within the institution helps ensure sustainability. So we are actually replicating this again now with a broader group of stakeholders in Chicago and Cook County. Again, maybe working with some health centers, but a lot of community-based organizations, and we're doing the exact same process again. And we're really excited to see the outcome. So I think that's all for me, but if you want to contact me or ask questions, I'm available, and thank you so much.
Thanks, Janna and Anna. It's incredible the work you've done with communities. I know you serve as reference and inspiration for the next cycle of SPAN state recipients. Now I wanted to turn it over to our last speakers, the Carolina Global Directors, Dana and Jessica. They're really true experts in human milk and the early care and education. I'll repeat, early care and education. Thanks to them, I'll never forget that the ECE acronym stands for early care and education. They have taught me on the correct usage that wasn't consistent in the first version of the blueprint document. So if you have downloaded the blueprint in August or September, please make sure to re-download it again, because the updated version of the blueprint document has the correct description of the ECE. Anyways, those two are the go-to experts in this field. Welcome, Dana and Jessica.
Thank you. Hello from the Carolina Global Breastfeeding Institute. I'm Dana Huntley, and Jessica Bridgman and I are excited to share today on identifying lactation continuity of care in the context of early care and education. We hope that by the end of our session, you'll have increased your confidence around connecting to your local ECE stakeholders. Our work in ECE is focused on implementing infant and young child feeding, or IYCF practices. We have pilot tested 10 steps to breastfeeding friendly childcare. We are working to adapt childcare program emergency preparedness and response plans to incorporate human milk feeding best practice. We created a platform for the National Collaborative for Advancing Breastfeeding and Childcare. We assisted in development of our state designation program and continue to serve on the advisory committee. We provide workforce development opportunities through online training modules on Breastfeeding University, technical assistance, consultation, and job aids. And we have a newly funded study which will conduct a landscape analysis on IYCF practices in North Carolina early care and education. Funding will also support development of an ECE tailored infant and young child feeding and emergencies pilot curriculum and a scan of breastfeeding friendly childcare practices across the US. We wanted to take a moment to define ECE to help inform our dialogue today. First, let's talk about setting. What settings are considered ECE? ECE takes place within early learning and development programs, which are defined by the US Department of Education as a state licensed or state regulated program, regardless of setting or funding source, which provides early care and education for children from birth through kindergarten entry. This includes, but is not limited to, programs operated by childcare centers and family childcare homes, preschool programs funded by the federal government, early Head Start and Head Start, and any non-relative childcare providers not otherwise regulated by the state. When we talk about ECE settings, we are not referring to childcare teachers alone. Early childhood educator means any professional working in early learning and development programs, including but not limited to center-based and family childcare providers, infant and toddler specialist, early intervention specialist, and childhood special educators, home visitors, related service providers, administrators, Head Start teachers, early Head Start teachers, preschool and other teachers, teacher assistants, family service staff, and health coordinators. This also includes childcare health consultants. The early childhood system is a comprehensive network of providers and services, all converging to support families. This is a system of care, community-based, data-informed, culturally and linguistically responsive, child and family-centered, grounded in developmental knowledge. When we talk about the childcare industry and the providers and educators in that industry, these are the folks that we're collaborating with in our work, and they sustain the field of early care and education. All right, now that we've described the innate diversity with the childcare industry, let's dive into some of the challenges faced by the childcare industry, which are key to guiding initial approaches to collaboration in the ECE field. This will help to establish a baseline of parameters for policy systems and environmental or PSE changes. Challenges include limited infant care across all programs. Centers and family childcare homes have a shortage of infant toddler classrooms. The next challenge is childcare deserts, particularly in rural areas, force families to reconsider plans to return to work or school. Another is workforce challenges. The median hourly wage for child caregivers nationally is nearly 40% less than all other jobs, a level that makes it more challenging to attract and retain quality staff to meet the needs of providing infant care. Here we're looking at North Carolina data, but this trend is reflected nationally. Teachers in the infant toddler classrooms have lower hourly wages than their counterparts in pre-K classrooms. The childcare workforce, which is roughly 93% female and disproportionately women of color, is among the lowest paying professions for degree holders, in line with the country's longstanding devaluation of care work. Despite childcare workers' essential role More than half of them rely on some form of public assistance benefits. Despite the challenges, the ECE workforce is committed to supporting lactating families. The workforce desires to obtain additional education about breastfeeding and want sessions delivered by health professionals and updated resources for themselves and families. You'll just click one more time. The link to this study will be in the chat for you. Next slide. Over the years, CGBI has developed materials to address breastfeeding support in ECE settings. On the CGBI website, you'll find 2 toolkits, and the link to this page is in the chat. The rest of our presentation today will introduce you to resources intended to help create PSE changes that proactively promote, protect, and support chest breastfeeding throughout the community. While internal CoC is occurring through BFCC 10-step practices, external bridges are at the same time being built within the local community. We know a key component of CoC is the consistent availability of supportive environments. This table compares 3 different 10-step breastfeeding initiatives you might be familiar with, highlighting tangible PSE opportunities across the built environment community-wide. Although designed for different environmental settings, the concepts or themes for each are similar and include emphasis on breastfeeding supportive policies, breastfeeding-friendly environments, information dissemination to families, professionals, and others in the community interacting with families, and recognize the impact of adequate and effective support for breastfeeding success. And the PDF link to this is in the chat for you. Getting into the Child Care Program Toolkit, it includes tailored information and materials to support childcare staff and families. Further, it provides continuity of information and instruction, particularly when there's high employee turnover and limited resources to provide continuous training. This toolkit consists of childcare program self-assessment materials, education and implementation, job aids, educational materials for all families, and educational materials specific to human milk feeding families. Self-assessment is one place to start when conducting a comprehensive analysis as described in strategy 2.2 of the NACCHO blueprint. While conducting self-assessments, we encourage childcare program teams to be completely honest, reflect on current practices actually happening, and remember, if you don't know what's happening, ask. For example, a director might not know what happens within a classroom and would need to ask that teacher about their practices. Once the self-assessment is completed, the toolkit offers guidance for developing action plans to meet the individual program's goals. This job aid encourages accountability through documentation of specified tasks. Action plan activities include brainstorming actions to reach defined goals, recording team members involved in executing actions for each goal, and setting target due dates to keep that action a priority and on a realistic timetable. Planning, documenting, and implementing actions fosters and strengthens buy-in among childcare program teams. The most widely shared job aid, which is included in the Childcare Program Toolkit and CoC Toolkit, is the infant feeding plan. It's a national childcare nutrition requirement for programs to maintain written plans. The infant feeding plan is used in childcare settings as a communication tool between childcare providers and all families, whether human milk feeding or formula feeding, and can be used for consistent messaging across the care continuum. It helps healthcare providers stay informed about what's going on in childcare and know the type of information childcare is requesting from families. It helps build the family's confidence that they are within a care continuum and not falling through the cracks of disconnected systems.
Next, we have breastfeeding supported here posters, which are also featured in both toolkits, and they can contribute to normalizing lactation in ECE settings. Posters were created for childcare settings, but can and have been used in birthing facilities and prenatal clinics to create breastfeeding friendly environments. And this goes along with strategy 2.7, which we will place into the chat for reference for you. As you'll see when you head to the resource download page, we have additional childcare program toolkit job aids as well. And so now we're going to talk about the CGBI CoC toolkit. So it evolved from collaboration with ECE professionals, lactating families enrolled in ECE, and healthcare providers, including the Enrich Carolinas Project breastfeeding coaches. So the Enrich coaches helped birthing facilities navigate the baby-friendly hospital initiative and/or state maternity center designation. So they are keenly aware of challenges healthcare providers face. And this collaboration with them provided an invaluable opportunity to connect healthcare and ECE. In our breastfeeding-friendly childcare work, we continued to observe common themes and trends and the types of questions being asked across all stakeholders that we work with. And we noticed misinformation being circulated as well. There's also recognition that these two systems, healthcare and ECE, were each critical to supporting lactating people and reaching their lactation goals. Yet they were frequently unaware of what one another were specifically communicating to lactating families. It became more clear to us that there was an opportunity to develop resources for healthcare providers to communicate accurate information to lactating families about ECE. So, for example, healthcare providers often may be unaware of lactation accommodations that are available within licensed ECE settings. And another example for ECE professionals, they may receive specific questions from lactating families that are best suited for lactation support providers, consultation, and referral. These resources in the toolkit complement one another, each providing different information. You can see them on the slide here to counter misinformation and gaps that we observed through our collaborations with these two industries. The CoC toolkit is our attempt at a solution to break these silos and offers communication resources with consistent messages for all caregivers supporting lactating families across healthcare and ECE settings. We do hope that the toolkit is a stepping stone to further developing the intersection of healthcare and ECE lactation support. The toolkit is a tangible, ready-to-use resource to help you get started and build these linkages that will break down existing silos on the lactation CoC continuum. So we do have instructions which introduce the toolkit and provide the purpose of each material. And the toolkit and actions section, which you can see here, of the instructions page offers recommendations on first steps. These materials are not intended for discharge packets. The idea is to present this information prenatally to allow families the time to process the information prior to birth and then be prepared as childcare questions come up for them versus a reactive approach. The RAT card is designed to provide families with knowledge of what to expect around lactation support and childcare settings, while also recognizing that human milk feeding best practices are a marker of quality care. On the front left side, there's a definition of quality care and how it relates to support for feeding practices and where to find information on local childcare. This is not a comprehensive list, but a starting point. And we wanted to frame the connection between quality care and feeding. And note here, this is the only resource in the CoC toolkit with versions tailored specifically to North and South Carolina. On the back right side, you'll see childcare rules around lactation support and how to report a childcare program if they're not meeting state requirements for lactation support. This is the only material that we developed with the intention of being given to families, even without discussion beforehand. We have included it in a toolkit of job aids meant for healthcare providers because many understandably may not know what's happening across their state's ECE settings, and therefore they can use the RAT card as a reference themselves. A recommendation to healthcare providers that we've worked with through Enrich Carolinas has been to make this available for families during childbirth and breastfeeding classes. The ECE stakeholders that we've worked with, such as the Partnership for Children, printed these with local funding to distribute to families through childcare programs they serve. Role confusion often occurs when it comes to lactation support. As a way to clarify expectations and scope of work for different caregivers, the guide outlines the role for different groups. So it outlines that for families, healthcare providers, childcare programs, and completing infant feeding plans. Even if not using this form, which you see on the screen now, it's important to keep in mind healthcare provider input in teams planning influences CoC. It identifies healthcare providers' role in supporting evidence-based infant feeding practices. ECE and families often have questions about milestones, and you can see one of the bullets here is educate families on paced bottle feeding and provide resources for other caregivers. The healthcare provider's role is to provide education on paced bottle feeding and developmental readiness for solids, including dietary modifications. And we do acknowledge that this may feel nebulous because likely this type of CoC isn't yet occurring in your community. We understand that this relational bridging along the care continuum may not be happening right now. However, as you begin to establish these channels for CoC, we're hopeful implementation of the toolkit will lead to CoC in practice and further building the framework to eliminate care continuum silos. We created an FAQ page, the provider being aware of common questions helps them be prepared with anticipatory guidance as these issues come up. Also, families may not even know what to ask. So let's take a look at a question here. What if the child care program asks for more milk containers, but parents are sending all that they're able to express? So this is an opportunity to help the family discuss appropriate intake per age weight and pace bottle feeding with other caregivers. Also, this is a prompt to discuss the options for supplementing and whether that's necessary. Feeding human milk from a sippy cup educates on how to serve human milk beyond infant classrooms, including information for families on how to prepare human milk for cup feeding at their child care program. We know that human milk is still the main source of nutrition as children transition to solids and provides health benefits throughout childhood. However, ECE professionals are often under the impression that provision of human milk should be from a bottle or would not continue after 6 months. After a conversation, if you feel it would be helpful for the family to hold on to one of the job aids, that would be okay. We would just encourage discussion with families. So for example, instead of just handing it to them, you would take the opportunity to rephrase or summarize in a way that you feel is appropriate for that family so that they can they understand clearly, since the language used to develop the job aids was prepared with healthcare providers as the audience. And this is a voice from the field, Norma Escobar. She's a lactation program coordinator at the New Hanover County Health and Human Services. And she facilitates our ECE provider training. And she has reviewed the CoC toolkit and began including it in her ECE trainings. As an IBCLC who also works at a local health department, we felt her opinion would be valuable to share with you. So we ask, how have you seen breastfeeding-friendly childcare impact ECE? Norma says, I've seen providers become more confident as they gain skills and knowledge. And mothers feel happier when with the care their babies get. When the center knows what normal breastfeeding looks like, they can provide moms with the support they need to overcome barriers and reach their feeding goals. Everyone wins. We also heard from Emily Engelhart, an early childhood specialist with the Partnership of Children of Johnston County, North Carolina. So Emily says, our county is in the beginning stages of breastfeeding-friendly childcare designations. When we do the BFCC training and TA, we see teachers and staff do a self-reflection about their feelings and opinions towards breastfeeding. We find that many providers don't know that much about breastfeeding and human milk. We go through debunking myths about breastfeeding, such as human milk is a biohazard. When providers are more informed, they are better able to handle human milk appropriately and accommodate needs of these families. They accommodate them by being knowledgeable about how to handle human milk, making a space, which you can see on this slide here as a space that she helped to support that creation of. So making a space other than a bathroom to pump or nurse, and educating all the children up through preschool about how natural and beneficial human milk is for human children. We would like to encourage you to use the toolkits we've shared as you begin building connections and explore local opportunities to collaborate with ECE. And in the chat, we'll leave you with some resources. And if you're not sure where to start to build connections with local ECE partners, a great starting place is Childcare Aware of America. We'll place that resource into the chat. States often have ongoing childcare quality enhancement initiatives. So there may be easy ways for you to embed breastfeeding-friendly childcare into those initiatives as you build relationships with local ECE stakeholders. This is part of recommendation 2.6, which is identify CHEST breastfeeding champions within organizations to lead and support organizational PSE changes. Next steps for the CoC toolkit. As we receive feedback, and we hope to be able to share that and lessons learned in the coming year. And as Dana mentioned, we'll be sending out a survey for the research that we're going to be doing. Excited about that. And always, please feel free to reach out to share your feedback and lessons learned. We always welcome that and enjoy hearing from others doing ECE work.
Thank you. Thank you so much, Jessica and Dana. You can see their references here. This amazing presentation, and thank you for your contribution to the continuity of care field from this ECE space. Now we can just put it together, all that we heard very quick, and wink, wink. This is where you're gonna find the answers for the post-test, right? So we talked about the second recommendation of the blueprint, and it's also the second part of continuity of care in breastfeeding support definition, a community-wide approach that is needed to establish this continuity of care everywhere, so to make CHEST breastfeeding a feasible choice for the communities. And those are done through lactation-friendly environments using the breastfeeding policy systems and environmental approach. So today you heard from early care and education settings, federal qualified health centers, employers, food pantries, human milk banks, and WIC. We also discussed essentials to develop breastfeeding-friendly environments, such as identifying champions, finding point of relevance for each organization. And finally, as you see from all the examples being shared here today, both the blueprint recommendations and strategies overlap from each other. As you can see from the ECE work, CGBI is working not just within their environment, but also linking to healthcare providers and consistent messaging and care accountability. Both of the REACH examples we shared are also working on recommendation 1, that is conducting a lactation assessment first to then understand what is next. So they did the cutouts based on identifying that there was a stigma for breastfeeding in public in their community. So we're gonna, before we get going with the Q&A here, just wanted to share the link we're gonna share in the chat box for the next webinar on recommendation 3, which is warm hand ups, referral systems and lactation care accountability. And then for the continuing education, so here for SERPs, you're gonna have to wait a little bit more, but we're gonna send the link when we share the webinar recording. But for CPUs, which is the credits for dietitians, you complete this first link here that you see on the website, and we're going to share in the chat box. For CMEs, CNEs, CHES, MCHES, CPHs, and CEUs, you're going to follow the second link here. You will go to the CDC TCO website, add this access code, which is today's date. And if you don't have yet an account, you're going to have to create an account with TCO. to receive this these credits after completing their evaluation survey. We will share all this information again when we share the webinar recording, so don't worry about it. So now I would like to invite all the speakers back to the Q&A. We have received a lot of questions, so I'm gonna get started with the first question we received here, and it's for Linda Kopecky, about relevance, one of the breastfeeding essentials. How to find funding to help employers if that is an issue, Linda?
The $64,000 question, isn't it? So sometimes there's grants, you can get them through public health. In Minnesota, we have some funding through the legislature that comes down through public health to fund these types of activities. Sometimes it's a local grant. Sometimes it's just an organization. So, you know, like the library may have Friends of the Library, or a hospital may have a hospital foundation, or a school may have a PTO. So there's a fundraising arm that's attached to that organization that maybe that particular organization can leverage a little bit of funding from them. So there's a variety of places to find funding. It doesn't have to be this big pool of funding that's sitting in public health that's going out to all the organizations. Sometimes you help organizations leverage some money from elsewhere to be able to fund those projects. And then quickly, I know there's a couple other questions related to some of the things we've done. I'll just cover those now. One is the resource list. And it's more of a resource bank. And we were actually, the impetus for this was really trying to restructure the MBC Workplace and Childcare Subcommittee. It had kind of lost its purpose and lost its way. So we spent a year trying to figure out what it could do that was complementing other partners across the state working in the area of workplace and childcare. And what we identified was they can be the subject matter experts, so like office hours to problem solve, and they can organize that resource bank. So this grant allowed us to create this resource bank, and it's going to be the Workplace and Childcare Subcommittee's job to maintain it. And that's a really good role for that state level subcommittee. And then quickly, experience with donor milk in a rural community. Cochichean County is 12,000 people, so it's even smaller than your county. That's a really, really rural county. And when we've talked about the whole donor milk piece up there, it's hard. They have so few families that are have children who are babies and small children. Their hospitals stopped delivering, so now people have to go to the next county to deliver. It's very challenging up there, and there's interest. According to the client surveys, people know what donor milk is. They're interested. They see the food pantry as a source of potentially donor milk, but the numbers just, it's hard to see a feasibility in that travel of getting the frozen bridge bags of donor milk to that food pantry for so few people. So it's going to be different connections and different partnerships that can increase access to donor milk for those families, and not necessarily bridge bags.
Thank you. Thank you so much, Linda. If you can, there's a few other questions. If you can type the answer, that would be great.
I'm happy to do that.
You can send it all. We also have some questions for CGBI. The first one is, can you speak more about the state designation for lactation in North Carolina and your impact there? Dana or Jessica?
Hi, thank you. That's a great question. We are hoping to get some more data around that as we roll out the survey that we mentioned in our presentation. Right now, we don't specifically have data that can kind of answer that, although we do hear from programs that do participate in the designation that it is beneficial for their community and their families.
Okay, thank you. Thank you. You see lots of questions asking about links. If you can type those links, that would be great. And then there is a question specifically for Dana here. Do you all reach nannies or nanny co-ops with any of these programs, or even like babysitter groups?
We have not spread out into nanny co-ops or babysitter groups right now. It's just been childcare programs and family childcare homes.
Okay, thank you. Thank you. Also, there is a question here. To whom were the CLC, CLS, certified lactation specialists and certified lactation counselors referring if the family needs additional, more advanced clinical lactation care? And I'm not sure if this question is for Linda or Janna and Anna.
I think that varied. In some cases, there were IDCLCs where they could refer at the hospital or at an outpatient resource center, but it was probably different for each FQHC or health center in our case. So it kind of depended on where they were, but having the CLC or CLS was an upgrade from what they had before.
All right, thank you. Thank you so much. There's more questions. We will do a Q&A sheet, and we'll send with the recording along with the bios of these amazing speakers. Thank you so very much, everyone. I think this was a great session from different perspectives. You can download the blueprint from this website, and if you do have any resources on establishing this breastfeeding friendly environments, please email us at breastfeeding@NACCHO. We would love to have it in the continuity of care repository so everybody can access those too. Thank you so much. And I want to close with this quote. It is unreasonable to expect that people will change their behavior easily where so many forces in the social, culture, and physical environment conspire against such changes. So thank you very much. I hope you appreciate all the learning and all the speakers, and have a great end of your day.